Okay. So, slideshow. Okay, I'm gonna go back. Oh no, go back to where I started. Okay, so I was talking about the anatomy of a virus, and I was describing this RNA enclosed in protein. And this is the spike protein that all these vaccines are targeting because it uses the ACE2 receptors that we have on our cells to get into our cells and be able to cause that damage. This is the lipid membrane. A little bit about the life cycle. I just described how this spike protein gets into our body using this receptor ACE2, and that's how it replicates itself. This is the whole process, and you have more of the virus coming out that way. So the common vaccine questions I'm going to try to answer, like why do you have so much hesitancy in the minority community, side effects, how do vaccines work? Is there microchip? All that those good questions. I'm gonna try to get to as many as possible. The recent CDC data on minorities.
Dr. Anyanwoke, can you hold on a second?
Sure.
Please, can you all mute your mic?
I'm going to mute everybody for now.
Okay.
I will set you up again. And this is Gertrude. Okay.
Okay. So recent CDC data on minorities and COVID-19, it suggested that Blacks, Hispanics, Native Americans have about 4 times hospitalization than white folks, and nearly 3 times likely to die of COVID than white people. However, we've seen that white Americans have been the ones that have been getting vaccinated at a rate 3 times more than Black people. CDC reported that at least for those who have received at least 1 dose of a vaccine, you have 5.4% of them being Black people and about 60% being white people. There is a recent poll that was out that suggested that 35% of Black Americans don't plan to get the vaccine. And their concerns are mainly safety and the fact that the vaccines are new. So why is there so much vaccine hesitancy in the minority communities? We all are aware of the fact that there's racism in medicine and in healthcare and the government policies. We know about the Tuskegee syphilis experiment, where Black men were intentionally denied treatment leading to mortality and morbidity. I think one of my colleagues will talk about this later more on a more informed basis. There's another example of the Henrietta Lacks case, where her cancer cells were used for research. She was never told about it. There was never any compensation for using her cells. And then we all are Black people, most of us here today, or minorities. We know that we face a lot of inequalities in the healthcare system. And this all leads to distrust and skepticism and hesitancy for our people to take the COVID-19. So past work on messenger RNA, I know that people want to know more about this because it's the first time they've used this platform to make a vaccine. But this has been ongoing for about 3 decades. This lady here, Dr. Kathleen Carrico, is very pivotal in this study. She started working on it in the 1990s. She thought about a unique way where you could utilize, since you use messenger RNA to make proteins, you could utilize a synthetic messenger RNA technology to combat different diseases. So throughout this period, she met with a lot of ups and downs, disappointments and all. And sometimes she almost gave up, she never gave up. But 30 years later, we are using it for this. She actually proved that this could work in mice 30 years ago in 1990 at the University of Wisconsin. But the problems they had was that the synthetic messenger RNA was not stable. And if in that unstable state, when it gets into our body, it can cause unintended risk to the immune system, and it could harm some patients. And because of that, a lot of people didn't want to fund her research because they felt like that was an insurmountable task. However, in 2005, which is 15 years later, they figured out the solution to the problem and tried to use the technology later on for Ebola a few years ago. In 2020, with the pandemic, I would say, preparation met opportunity, and they were able to deploy this technology. I also want to let us remember that there are a lot of minorities that worked on this vaccine, especially Dr. Kizzy Kober, who works at the NIH lab. She worked on the Moderna vaccine with other scientists at the NIH. And according to Dr. Fauci, she was very instrumental in the development of this vaccine. So vaccines work, we know that, because this here is a schematic of Ireland in 1950 and in 2019. You see the bigger the bubble, the more the disease, and the smaller the bubble, the less disease. This here is as a result of vaccinating people. So how do vaccines work? We get a little bit amount of a harmless form of a disease or something that looks like the disease. Then our bodies make antibodies to fight it off. Then if we encounter that disease again, boom, our body has the antibodies, and so it's ready, our immune system is ready to fight so that we don't get sick. This messenger RNA for spike protein of coronavirus gets injected into our upper arm, and the muscles there, the muscle cell, the messenger RNA uses the ribosomes in the cytoplasm of those cells to produce the spike protein. When the spike protein is produced, the body recognizes that, oh, these people are foreign. So the spike protein acts like the antigen, acts like the virus itself. And so the body starts producing antibodies. The T cells are all awake. The lymphocytes, so both the beta lymphocytes, T lymphocytes form what we call the memory cells, such that if we get that infection again, or if we get coronavirus, our body will be able to take care of it. I wanted to describe a little bit about the messenger RNA. So we have DNA. DNA is the double-stranded, that's where our genetic material are. And usually the DNA will come and translate into messenger RNA that has like amino acids. So the messenger RNA's job is always like the DNA gives it some genetic material, like, okay, go and do this message for me. I want you to produce this kind of protein. That's really the job of the messenger RNA. Most organisms, majority of organisms have double stranded like DNA. A few viruses have just RNAs, which are single stranded. So each codon corresponds to one amino acid here. And these amino acids form into polypeptide chains. And these polypeptide chains can form into protein. They collapse together, and that's what you get. I wanted to describe a little bit about the messenger RNA here. This is the 5' region. This is the 3' region. This is the tail. This center right here is where the coded message, the synthetic genetic code, is put in. It's not going to go back into your DNA because a message has already been sent. There's already an RNA to do the job. People always ask, was the process rushed? I say yes, it was an accelerated process because of the effects of the COVID-19 pandemic in the whole world. Children couldn't go to school, people couldn't go to work, we're always in the house. And so it was a serious problem. And so the government wanted to be able to help. Usually, this is Operation Warp Speed. I think the name that they gave it didn't even help because everybody's like, oh my God, the speed with which they produced that vaccine. Yes, it was accelerated because the world economy and everybody's life was turned upside down. So if you look here, the typical process takes about 73 months from beginning to end. I want everybody to realize that even though this process was accelerated, it never skipped a phase. What it did was some of the phases, it doubled them. Like you see how over here, you had 3 months here and 5 months here. It used 5 months for that 8 months process. And here you usually get 21 months. This blue one here is phase 1. For a normal large study, it could be anywhere between 2,000, 3,000, maybe 4,000, 5,000. That's huge study. For COVID-19, we were able to get thousands and thousands of patients because of the significance of what it was doing to our society. So we had enough patients and they went through rigorous processes in the production of the vaccine. So yes, it was accelerated, but no process, no stage was skipped. If you look here, Right here is the manufacturing production stage, right? Usually it's here, but they were already producing it. Why did that happen? Because the pharmaceutical companies were not going to lose any money. The government was like, okay, you know, if you produce this stuff, we're going to pay for them. We're going to take the risk to pay for you to produce it. And even if it doesn't work, you don't lose the money. So they went into business and they started producing it. I was talking about the vaccine being accelerated, but no corners were cut. And I talked about the studies. Usually the largest you could get is 4,000 to 5,000 people. Well, see, for Pfizer got, this is the together, vaccine and placebo, together is 37,000 people. Moderna had 30,000 people. AstraZeneca had 30,000 people. Janssen, which is the J&J one that had just come out that they are going to get to FDA for approval, had 60,000 people. There are others that are still in development. So were minorities included in the studies? Yeah, minorities were included. If you put them together, the 82% of the people were white. And here you have 10% Black people, 8% Asian, 26% are Hispanic. Sorry, this is okay, this over here is distribution by sex, which is 51% male and 49% female. So is the vaccine safe? Yes, because it's gone through all this rigorous process to ensure safety. And there are systems that are in place for CDC and FDA to, you know, when you manufacture a drug, there are certain things you have to do. And the vaccine didn't skip a phase. It went through them all. According to Bloomberg, today, as at 4:55 Central Standard Time, more than 124 million shots of the COVID-19 vaccine has been given. In the US, it's been 38.5 million doses that have been administered. And like I said, worldwide is more than 124 million. And it's, if you look at how many people have died from contracting the virus itself, and you look at 124 million shots have been given, and nobody has really died that has been really established that it's the vaccine that caused it. So you know it's way, way, way highly safe. So is the vaccine effective in all the populations? This is what they did. For Black people, the vaccine actually worked 100%. For white people, it was 95.2. And for Hispanics, it was 94.4. So the overall vaccine efficacy by the time you calculate all that is 94.6%. If you go by the age, people that were greater than 75 years old, they had 100% effectiveness. For greater than 65, it was 94. For greater than 55 was 93.7. 16-year-old to 55-year-old was 95.6. And by sex, men was 96% efficacy and 94 for women. In our communities, especially in the Black communities, they have people talk about mark of the beast, 666. That has nothing to do with this vaccine. It has nothing to do with it. It is very unfortunate that people have been, you know, inducing fear amongst members of our communities and with these baseless lies. And this, what bothers me is that this can endanger people's lives because it can prevent them from actually taking what's going to help them. And then people talk about the vaccine containing microchip. It's not true. It does not contain microchip. It's a false narrative, and it's highly misinforming the people. And I worry that this misinformation may actually become harmful to our health, to the health of our members of our community. And again, it might prevent us from taking the vaccine. People say that the hydrogel nanotechnology, you know, they use to deliver the mRNA vaccine means that, you know, we've introduced microchips because you also have nanotechnology in microchips. The word nano, all it means is very tiny. Because I talked earlier about this messenger RNA not being stable, they had to use like a tiny fat bubble, tiny molecule, fat molecule, to wrap the messenger RNA so that it's not so unstable until it gets into the body to do the job it's supposed to do. That's the only reason why you have the lipid nanoparticles. And that nanoparticle has nothing to do with microchips. Now, people talk about the government tracking the vaccine and all. It's not biologically possible for the vaccine that we got to be tracked by microchips. Again, I said there's no microchips. And what they were talking about is, here is the Pfizer package, because it requires such extra cold storage. The way they packaged it, they were going to put it in this box. They have 5 of these boxes. They put in this big box, and then they put it in this bigger box that has dry ice. So what they did was they put like a thermometer in here that is Bluetooth, and it can be tracked to know where this package is at any time. Now, this thermometer and this Bluetooth tracking device is only tracking the package. It's not tracking the medication or the fluid inside the vaccine itself. So it cannot track us. So what are the common side effects? The arm where the shot it goes into might have some soreness, swelling, pain. Some people might have fever or tiredness or chills or headache. Helpful tips if you have pain or discomfort, you can talk to your doctor about taking over-the-counter medications like Tylenol or ibuprofen to reduce the pain and discomfort. Sometimes you can apply clean, cool, wet washcloth over the area. You can exercise your arm if you can. To reduce fever, you want to drink plenty of fluids, dress lightly. So are there serious side effects? Yes, there are serious side effects, but they are very rare. CDC has learned of reports, this is from the CDC website, that some people have experienced severe allergic reactions, also known as anaphylaxis. And that was after getting the COVID-19 vaccine. Some people that have allergic reaction had this. It's about, the last count I had was 8 people so far. And I just talked about more than 124 million people have gotten the vaccine. A lot of them already had history of allergy. So what they do is they use their EpiPen that they usually use for their allergy to treat them. And all of them were fine. People talk about what about the new UK strain, South African strain, by Brazilian mutant strains in the news. I'm going to, after I finish this slide. The new COVID-19 virus mutations have been identified in UK. That one is the B117. In South Africa is the 501YV2, and Brazil is B1128. These numbers here are at the position where there is the mutation. So talking a little bit about viruses. Viruses mutate all the time. And that's one of the problems. If we don't arrest this virus and the viral infection, they're going to keep staying in the community. And each time they infect people, they're going to keep changing because they reproduce so fast. There is room for a mistake. And that mistake is what is a variant. Most times, the mistake, like this virus has mutated thousands of times. Most of them are inconsequential. But however, the strains that we're seeing right now, they have consequences. Like the N501Y that's found in both UK and South Africa may facilitate the virus to replicate even faster. The E484K found in South Africa and Brazil may actually affect the ability of the immune system to recognize the virus, even if you had COVID and now you have natural immunity or you have vaccination. The UK variants have been found in a lot of countries around the world, including the US, and there's projection that it's going to be the dominant strain here very soon. There is a Nigerian strain that was talked about more than a month ago, as at this time we're still waiting for them to give us the sequencing of that Nigerian strain. So I do have more slides, but I will have Professor Uweze post it on your website, and we can go from here. Thank you.
Thank you so much for that informative session. Since I've known you, you've never disappointed me. That was excellent. I see that a lot of questions in the chat room. There'll be a lot of questions for you. So we want you to rest while we go to Dr. Adeniyi.